Well, welcome everyone to today's specialty testing webinar on autoimmune movement disorders. My name is Ben Levno. I'm a senior product manager here at Mayo Collaborative Services. And our presenter today is Dr. Andrew McKeown. Dr. McKeown is the co-director of the Mayo Clinic Neuroimmunology Lab here in Rochester, Minnesota. He's also a practicing neurologist and professor of both laboratory medicine and pathology and neurology here at Mayo Clinic. Just a couple of things to remind everyone before we begin today. There will be a question and answer period at the end of the program. You can submit those questions online via the Q&A icon on the bottom of your screen. Please only use the chat function for technical issues. Also, today's program will be recorded and be posted to our website in just a couple of weeks. And now I'll turn it over to our presenter, Dr. Andrew McKeown. Thanks for joining us today, sir.
Thank you very much, Ben. And thank you everybody for joining. So here are some disclosures related to funding for some of the research into new antibodies that I do in the lab with my colleagues, and then some disclosures related to partnerships with industry and also clinical trials, and also related to our commercialization of antibodies discovered in the lab. So the purpose of today's talk is to give an overview of what are autoimmune movement disorders, and to discuss in detail then what the phenotypes of the patients are, the type of testing that we think about to order in patients with suspected autoimmune movement disorders, how we evaluate those patients, particularly focusing on autoantibody testing, and then how we might consider working up those patients when we do find an antibody, and what sorts of considerations we make in terms of cancer associations of these antibodies, treatment considerations, and prognosis. So the autoimmune movement disorder spectrum is really quite similar to the movement disorder spectrum in general at this stage, although some phenotypes are more commonly associated with autoimmunity than others. So in particular, the cerebellar ataxias, in terms of frequency of cases, this is probably the most common autoimmune movement disorder that we see. But then there is a whole spectrum of disorders or clinical findings that can be encountered in patients with brainstem encephalitis, where they either have a disorder that really is mostly cerebellar ataxia, but some additional findings, or they can have a disorder with predominance of dystonia, postural instability, rigidity, which can look like Parkinsonism, particularly the Parkinson's plus disorders. And then there's a whole slew of hyperkinetic movement disorders, which we'll go through as well. And then lastly, but not least, the stiff person syndrome spectrum. And just to demonstrate early in our talk, the workhorse assay that we use in the lab for detecting a lot of these antibodies is mouse brain-based indirect immunofluorescence, where we apply patient serum or spinal fluid to mouse brain, a mouse tissue composite that includes brain, kidney, and gut. The kidney and gut is controlled to exclude non-organ specific binding. And then we can make a diagnosis of an antibody based on immunohistochemical criteria, and then reflex that to a protein specific assay to confirm. So that's really the whole basis for our diagnostics. This particular antibody you're seeing here is CRIM5 antibody. So broadly speaking, the antibody biomarkers that we detect in the lab, they fall into two groups. So while they're all excellent biomarkers, not all of them are disease causing. So some of the antibodies that you can see here in red target cell surface receptors, ion channels, such as mGluR1 or PQ-tycalcium channels. And to varying degrees, these have been shown in the literature to have pathogenic effects. So removing these antibodies through treatment like plasma exchange and then giving rituximab to prevent antibody production ultimately can lead to clinical improvements and even remission in some cases. On the other hand, there are other autoantibodies that are, again, excellent biomarkers, but are reactive with intracellular antigens rather than cell surface antigens. And so in vivo, those antibodies cannot enter into the cell, into the neuron or the glial cell, and cause neural injury, but they are biomarkers of an accompanying T cell mediated process. So the effectors are cytotoxic T cells very often in these cases, possibly cytokines and chemokines as well. But the bottom line here is a lot of these antibodies are associated more with the classical paraneoplastic paradigm of severe cytotoxic T cell mediated illness with neuronophagia and ultimately atrophy of areas of the nervous system, resulting in more permanent injury. Now, this is quite a simplification, but for some antibodies like PCA1 or anti-O, that's very true, very hard to treat, very good diagnostic test, but ultimately treating the antibody doesn't tend to bring about improvements, and very often patients progress through treatment. Some other ones, though, PRIM5, we do sometimes see responses to treatment. So, but the emphasis very often with these particular antibodies is looking for the occult cancer, the underlying cancer causing the problem. So to start with the phenotypes then, we show you some examples of a patient with cerebellar ataxia. This patient had ataxic dysarthria.
And just have you say it's a sunny day in San Francisco. Yeah, it's a sunny day in San Francisco. You say la 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 la.
But also you could see that he had coarse nystagmus with this as well, and he had a pancerebellar syndrome. So this particular patient had an antibody discovered in Mayo Clinic known as septin-5 antibody. Typically, we don't, or to date, we've not found cancer in these patients. So this is really just to emphasize that all the time we're discovering new antibodies that are biomarkers of autoimmune ataxia, in addition to the whole slew of other antibodies that you can see above here that are now biomarkers of autoimmune ataxia. So the big clue here for an autoimmune cause is the subacute onset. So rather than it being insidious in onset with progression over months to years, these syndromes come on over days to weeks usually, as was the case in this particular gentleman. The other thing that is kind of note here is that the patient had diplopia accompanying his ataxia, which has been almost universally the case in the septin-5 cohort of patients. The patient below that is a woman with cerebellar ataxia. So historically, somebody with subacute onset of ataxia in her 50s, people would think, oh, we should test for anti-O or PCA1 antibody, which is true, but it turns out that she didn't have that. She had actually quite a mild cerebellar ataxic syndrome, which would be unusual for PCA1 or anti-O, and it turns out that she had metabotropic glutamate receptor 1 autoimmunity, or mGlu1 autoimmunity. And unlike the PCA1 cases, she responded to immune therapy. So again, another reason why we want to do a profile-based approach for antibodies and movement disorders is that consideration, not just of making the diagnosis, but also, okay, what is the likelihood of this patient responding to treatment, but also what is the type of cancer that we might look for in this patient. So mGlu1 is associated with either Hodgkin's disease, non-Hodgkin's lymphoma, or as in this particular patient, no cancer found. PCA1, on the other hand, in almost all cases, we find either breast or gynecologic malignancy. So the particular septin-5 antibody, again, we recognize this through the immunohistochemical criteria for septin-5. And so we found this particular staining pattern in a number of patients that you can see here on this Western blot below the MRI scan here. And so they all had the same molecular weight and reacted with the septin-5 protein. And so this is what helps us recognize it in the laboratory. And as you can see here, it co-localized very well with the commercial septin-5 antibody on IFA also as well. So then moving on to brainstem encephalitis. So this is a case that I think is illustrative of the clinical complexity of these patients. So again, subacute onset, but quite a diverse array of symptoms that this patient had. So like an ataxic case, he had imbalanced gait and coordination, but also had quite complex eye movement problems as well. So you can see here that he had seesaw nystagmus, which generally localizes to the brainstem. And then he had also other features that were suspicious for, okay, this is just beyond cerebellar ataxia. This is more in the brainstem realm, with him having superimposed opsoclonus that was seen at times. And then jaw dystonia, jaw opening difficulties, jaw clenching episodes, drooling, but then also sleep disorders. So severe daytime hypersomnolence, and then sleep-related complex motor behaviors, screaming and shouting vocalizations in sleep. And then as time went on, he also developed dystonia of his larynx. So he got laryngospasm that was resulting in choking episodes and nocturnal stridor, and then acute respiratory failure that led to intubation. So with this kind of subacute presentation, with this kind of complex array of brainstem symptoms and signs, brainstem encephalitis would come to mind. His initial evaluation did reveal some clues to potentially either an autoimmune or infectious cause with this elevated white cell count. Typically, CSF exclusive oligoclonal bands would indicate autoimmunity, but you can occasionally see this with other causes too, so you have to be kind of careful. And he did have some T2 signal abnormalities in the brainstem. Again, that could be seen with infection and not just autoimmunity. So the type of infection that you would think of for brainstem would be listeriosis. Other subacute onset brainstem disorders are listed here, some immune mediated, others related to carcinoma, and so on. Parkinson's plus disorders, in our experience, patients with classical PSP phenotype or the Richardson syndrome phenotype with a supranuclear gaze palsy and gait instability and axial rigidity in isolation do not have these problems, and typically they're more slowly progressive than brainstem encephalitis. So the autoimmune differential diagnosis for brainstem encephalitis includes this list of autoantibodies that we have here. In this particular patient's case, he was found to have both ANA2 and CALCH11 antibody, which was an unusual combination. And the atrophic testis became a clue as well. So very often with an atrophic testis, there can be a history of malignancy that's essentially burned out, or there may be a retained tumor somewhere, or retained testicular tumor in the pelvis. Or in this particular patient's case, it was essentially found that it was in a lymph node, and that's where the tumor was found. This also is illustrative of an important fact to bear in mind with paraneoplastic disorders, which is that the cancer is often quite small and quite hard to detect. So if you find a particular antibody that's strongly associated with cancer, there has to be kind of quite a detailed assessment looking for a tumor. And then if there's a very high predictive value for cancer with that particular antibody, 70% or higher, then repeating testing 6 months down the road and for every 6 months for 2 to 3 years is generally recommended. So in his particular situation, he was treated with IV methylprednisolone and cyclophosphamide. He had gradual improvements, but still had quite a lot of disability at the end of this. We also have to remember the importance of symptom-directed treatment as well. So for instance, botulinum toxin therapy for jaw dystonia. So for the CALCH11 autoantibody, again, this is one discovered at Mayo Clinic in collaboration with colleagues at UCSF. In addition to the brainstem encephalitis, also known as rhomboencephalitis, some patients can present with limbic encephalitis. Like I mentioned with the septin-5, where you can have a clinical feature that might be a clue, that also applies here with CALCH11. but in this particular situation, it's hearing loss or cochlear vestibular type disorder. So tinnitus could be another clue as well. So just to illustrate that the spectrum can be somewhat broad with one particular antibody, I showed you there a patient with Calc11 with a very complex brainstem encephalitis. This particular patient, though, was a little different in that he had predominantly just the ataxic phenotype. So he had the nystagmus and the gait disorder. But quite disabling nonetheless. The ANA2 antibody, again, is that the associations are not just one thing with the brainstem encephalitis. Some patients could present with a more isolated opsoclonus myclonus syndrome. And also there are patients who can develop limbic encephalitis with that particular antibody. So again, it isn't one antibody for one disease or one disease for one antibody. So with this particular patient, you can see that unlike the prior patient who had kind of more of an ataxic phenotype, she was more of kind of an akinetic rigid phenotype, which might make you think of PSP, but unlike patients with PSP, although she has some supranuclear gaze palsy, she also has the esotropia as well and has bilateral ptosis. So quite an atypical presentation for something like PSP. But she also had the jaw dystonia and neck rigidity. So we've had a couple of patients like this, both have breast adenocarcinoma, both women. And the second patient that we had, not this particular one I'm showing here, but we had another patient who had, in a previous series, who had a good response to cyclophosphamide, and her jaw dystonia responded to botulinum toxin, but unfortunately she developed recurrent laryngospasm that required tracheostomy, and so that was a residual disability that she had. So here's another patient with a very similar sort of phenotypic presentation, with the gait instability, rigidity, but also supranuclear gaze palsy. And he was initially thought to have PSP, but because of the rapid progression and he had features of narcolepsy, people were thinking, okay, this is not typical for PSP. And he had MAV1, MAV2 antibodies in combination, and ultimately had a tonsillar carcinoma found. He was treated with cyclophosphamide. We didn't have any follow-up on him for that, and he was given modafinil for his narcolepsy. So the next thing to discuss here a little bit about is the stiff person spectrum. And so these patients have some localization to the brainstem, but also the spinal cord, where the inhibitory interneurons are affected by this autoimmune process. And so this results in too much excitation, diffuse stiffness and spasms in the body, classically involving the bilateral lower extremities and the trunk. But there are patients who can have a whole body form accompanying seizures known as PERM. And then there are some patients who have a more focal form known as stiff limb. And the most common antibody we find in these patients is GAD65 antibody. In 80% of patients, glycine receptor and alpha-5 antibodies are found in a minority. The alpha-5 phenotype is more of a myeloneuropathy, so they can have stiffness and spasms, but typically they have peripheral neuropathic signs as well. Glycine receptor antibodies most commonly associated with the PERM phenotype, though occasionally we can encounter it in classical stiff person or in patients with stiff limb. So here's a patient with that, and so You can see the exaggerated lumbar lordosis. It doesn't quite flatten out when she lies flat, and that's because of the extensor paraspinal hypertonia, and then has difficulty flexing forward because of the proximal lower extremity and low back stiffness. You can see the way her muscles are pulled in her back. So it's a very classical stiff trunk predominant disorder. So it's worth mentioning also the GAD65 antibody is very common in the general population. About 5 to 8% of healthy individuals have this. It's present in about 70% of type 1 diabetics. In patients with stiff person syndrome or other GAD65 related neurological problems, we find the antibody is orders of magnitude higher than those populations I just mentioned. So, for example, a normal healthy individual could have a value of 0.04 nanomoles per liter. A type 1 diabetic could be around 1.00 nanomoles per liter, whereas a patient with stiff person syndrome could have a value of 500 nanomoles per liter. The DPPX antibody is also a marker of this PERM, or progressive encephalomyelitis rigidity of myoclonus. That's the most kind of famous phenotype associated with this, though there are other phenotypes that we've seen, particularly cognitive disorders. IGLAN5 is a marker that's worth spending a little bit of time talking about. This is one that is now recognized as being fairly common, perhaps even as common as the fifth most common autoantibody that's detected in autoimmune movement disorders. And the phenotypes can be quite diverse. So initially what was reported in these patients was either chorea, Parkinsonism, cerebellar ataxia accompanying very severe sleep disorders. And here's an example of a patient with kind of a neuropsychiatric syndrome and chorea behavioral phenotype. But she also developed she developed not severe, but she had some clinical evidence of mild sleep apnea, but unfortunately died in her sleep. And so the thought is that she probably had central hypoventilation related to this disease. So that's kind of the classical phenotype, and she didn't have response to immune therapy. Another patient here that was kind of a historical case who had more of an akinetic rigid syndrome is associated with myarrhythmia. As you can see here in her face, she was initially thought to perhaps have Whipple's disease. But she also had the jaw dystonia that we've seen in a number of the other videos that I've shown you today. But as time has gone on, it's emerged that there are a lot of other phenotypes encountered with this particular antibody. There have been patients with motor neuron disease mimics. Dysautonomia as a prominent feature has been encountered as well. And then there have been some patients with encephalopathy. And some of these patients are treatment responsive, and not all of them go on to develop the more severe phenotype that I showed you in that previous patient. To date, there hasn't been a paraneoplastic association noted with this, but I think it's worth bearing in mind for the kinds of phenotypes I mentioned, and some of the patients are immune treatment responsive. So where do these kind of various disorders then kind of fit into the overall rubric of neurological autoimmunity? Well, if we take autoimmune encephalitis in terms of our own outpatient clinical experience, there are many patients with kind of a definite limbic encephalitis, including things like NMDA receptor or other disorders like NMDA receptor encephalitis or ADEM, and then other patients with kind of more of a possible autoimmune encephalitis where it isn't as well defined. But as you can see here, brainstem encephalitis is relatively common in comparison to other disorders such as limbic encephalitis. So we do see these disorders quite commonly in our clinic. But it's also important to bear in mind that the current autoimmune encephalitis criteria, if you try to apply that to brainstem encephalitis, it generally wouldn't be applicable, because patients with brainstem encephalitis generally don't have cognitive impairment. So they have the subacute onset of problems, but they don't tend to have short-term memory loss or altered mental status. So what about chorea then, and where does that fit into this whole discussion? So we've mentioned a particular antibody so far that has been associated with different phenotypes, including IGLAN5, but there are a lot of other antibodies associated with autoimmune chorea. And so here's another video of a patient who, again, like the last patient, not just the choreiform movements, but also had subacute onset behavioral change as well, disinhibition. So a lot of the time with these patients, it's considered initially, okay, they could have Huntington's disease, but typically don't have any family history of chorea, may have a family history of autoimmunity, but not chorea. And then just the rapid progression is another clue.
You touch your nose or your right.
And what we have found in Olmsted County, Minnesota, is that after Huntington's disease, autoimmune chorea is the next most common cause in adults. So these disorders can be hemichorea, they can be generalized, or they can start off with a focal distribution and become generalized. And they break down into two broad groups. So you can have the paraneoplastic disorders associated with CRIM5 antibody, ANA1, ANA2 in some cases, amphiphysin. And they would have the usual accompanying cancers, usually small cell lung cancer in these patients. And they tend to have a fairly poor prognosis. They sometimes have coexisting peripheral neuropathy. Whereas those that have more of the lupus phenotype, so they have lupus antibodies, may have a history of other manifestations of lupus or antiphospholipid syndrome. These are patients without cancer found and tend to be steroid responsive. So as mentioned, the paraneoplastic disorder patients are older men, more frequently have weight loss, more frequently have coexisting peripheral neuropathy, whereas the lupus Sjogren's patients are often of a milder course and improve with treatment. From a radiological perspective, sometimes you will see these classical T2 signal abnormalities in the basal ganglia, but more commonly than not, the MRI scan is normal. And here is one example of a disorder where we do see the T2 signal abnormality in some cases. And this is PDE10A autoimmunity. And so this was observed first in patients with hyperkinetic movement disorders who had received PD-1 checkpoint inhibitors. So these are cancer immune therapies that unleash the T cell repertoire on cancers by blocking the immune checkpoints. As a result, though, these patients do have an increased risk of autoimmunity, including paraneoplastic neurologic autoimmunity. So here's an example of a patient who had that particular disorder. She had metastatic renal cell carcinoma that responded very well to PD-1 inhibitor. So she had kind of a chorea dystonia phenotype, so you can kind of see the platysma and facial contraction. So it's sort of more considered dystonia, but she also had some choreiform movements. She was treated with some immune therapy, perhaps had some mild improvements. She actually got the most benefit from tetrabenazine. So again, a good reminder that we don't just rely on immune therapies to treat these patients. symptomatic treatment is important too. So myoclonus then, so the chorea form movements you can see are kind of riding dance-like movements that move from proximal to distal. Myoclonus is lightning-like muscle twitches that can occur in various distributions. Opsoclonus myoclonus syndrome being the classical autoimmune phenotype. In fact, the opsoclonus myoclonus is universally an immune-mediated phenomenon. So either autoantibody associated or it could occur post-infectious or sometimes occurring in chronic HIV infection. There are other phenotypes such as isolated opsoclonus, which again I think is typically an immune-mediated phenomenon, and then generalized polymyoclonus, which has a more diverse differential diagnosis, including metabolic disorders, toxic disorders such as exposure to SSRIs and SNRIs. And then there are some patients who could have orthostatic myoclonus, so myoclonus just occurring on standing up. So here is an example of opsoclonus myoclonus syndrome. So you can see the lightning-like movements of the extraocular muscles, and then diffuse tremulousness of the limbs and trunk. So this patient did not have an antibody or a cancer found, but just recognizing the phenotype and knowing that, okay, this is something immune-mediated. He was treated with immune therapy and had a complete response to a combination of corticosteroids and IVIG. So again, diverse autoantibodies associated with the opsoclonus myoclonus syndrome. Here is a patient with isolated opsoclonus who had ANA2 antibody detected, and she ultimately underwent PET-CT imaging in the hunt for the cancer that we associate most strongly with ANA2 in women, which is breast adenocarcinoma. And this small area of hypermetabolism was detected in her breast. And ultimately, that was what was diagnosed in her, was adenocarcinoma. So again, just demonstrating how small these tumors often can be, and can be hard to detect by routine testing, such as mammography. And here's just an example from the literature of a patient with orthostatic myoclonus in the setting of Caspr2 antibody. So orthostatic tremor is kind of a classical movement disorder, not associated with autoimmunity, where patients find when they stand up, they become very unsteady, but once they walk, they're more stable. And often the tremor is transmitted to the arms when they're standing up. Orthostatic myoclonus, which can be differentiated from orthostatic tremor clinically by looking for rhythmic for tremor versus non-rhythmic for myoclonus, or indeed using electrophysiology, as you can see here, using surface EMG. The distinction is important because autoimmunity is a consideration for orthostatic myoclonus, but not for orthostatic tremor. So for dyskinesias, we've talked about, okay, in the hyperkinetic realm already, we talked about chorea, the dance-like movements, myoclonus, the lightning-like movements. Dyskinesias are really sort of just a kind of an umbrella term for a number of different movements, hyperkinetic movements. You can see here for this particular video of a patient with NMDA receptor encephalitis, these kind of more non-specific dyskinetic movements. Here is a child with NMDA receptor encephalitis who had these kind of automatistic type movements of the tongue. Isolated dystonia, so dystonia meaning co-contraction of agonist and antagonist muscles, resulting in muscle contractures, spasms. It's an unusual phenotype for a patient to have isolated dystonia in an autoimmune context. There were or there have been some reports of this associated with thyroid autoimmunity. And worth also mentioning pseudoapitosis. So you can see this is a patient with these writhing movements of the fingers resulting from deafferentation. This particular patient actually has multiple sclerosis, so this is resulting from a cord lesion. But the reason to demonstrate that is you could potentially come across that with an ANA1 or anti-HU or other neuronal antibody-associated sensory neuronopathy or sensory ganglionopathy. And then what about tics? And so there have been some patients who have had a streptococcal infection followed by the subacute onset of tics, OCD, and sometimes chorea. And certainly that this is kind of a pretty rare phenomenon. It's generally considered to be bona fide autoimmune and responsive to immune therapy. However, there are kind of a number of other patients who have positive anti-structural lysin node titer and have diverse neuropsychiatric phenomena, and it's quite controversial as to whether these patients have an autoimmune disease or not. D2R antibodies or dopamine 2 receptor antibodies have been reported and seem to be a marker for pediatric autoimmune movement disorders. So as far as the evaluation goes, I think really want to really emphasize the importance of defining the phenotype. First of all, subacute onset. Almost all of these disorders are subacute onset, so over days to weeks. AGLON5 can be more insidious, so I wouldn't say being insidious in onset would rule it out, but certainly kind of we're not looking for, you know, patients with insidious onset, classical degenerative movement disorders such as patients who have features of MSA, PSP, but you know, or have family histories of the same problems. We're not looking for autoimmunity in those patients. Paraclinical things that can help would be MRI findings for areas that might be suspicious for inflammation in the basal ganglia or the cerebellum or brainstem. And for the myoclonic disorder, sometimes if you have availability for a surface EMG study, that can be helpful as well to define the phenotype. For the immune testing, then non-neural antibody testing can be helpful, particularly for the choreas, thinking about phospholipid antibodies and lupus markers. But then also the CSF evaluation for particularly cell count, IgG index and synthesis rate and oligoclonal bands, or kappa-free light chain testing, which is another way for measuring, instead of measuring antibodies in general in the CSF, instead of oligoclonal bands. And then antibody profiles, we would typically recommend autoimmune movement disorders evaluation or the stiff person evaluations for that particular phenotype. So the way we would generally approach this is there's a lot of autoantibody testing in our lab, but we restrict it down to the specific antibodies that are pertinent to those phenotypes. And so by way of example here, we've got the movement disorders. So some of those antibody tests that are done by ELISA or done by radioimmunoprecipitation assay, but most are done by indirect immunofluorescence assay, recognizing this tissue staining pattern for DPPX in this particular example, then reflexing it to a DPPX specific cell-based assay. And then for some of the other autoantibodies, such as the ANA1 or alpha-5, we would use a line blot technology. So the bottom line is recognizing the pattern on tissue, it meets criteria, then reflexing to either a cell-based assay or line blot for the particular antigen of interest to confirm positivity. So this assures high specificity. And then a more restricted phenotypic evaluation for a patient with a stiff person phenotype. So while the movement disorders evaluation would be pertinent for ataxias, chorea, brainstem encephalitis, myoclonic disorders, the stiff person phenotype is requires really just a more limited autoantibody evaluation. And so then once we've done all of this assessment, then for either of these evaluations, we report out with comments pertinent to the neurological disorder, comments pertinent to cancer or likelihood of cancer, and then the cancer type that one might need to look for, particularly with the strongly paraneoplastic antibodies. And then we'll give academic references of papers that the providers can read about the evaluation and management of those patients. So for autoantibody associations, you probably recall from the first few initial slides I showed you that there are antibodies that are reactive with intracellular antigens that are more indicative of a T-cell mediated disorder, typically paraneoplastic. And so you can see the list of cancers associated here, and you can see the ones that kind of really stand out are small cell carcinoma for a lot of the antibodies, but then with the big exception being PCA1 or anti-O, which is associated with gynecologic and breast. The ones I've highlighted in green are essentially ones where there's really no cancer association known, or where the cancer association is very rare or occasional. So then for the cell surface directed antibodies is more of a mixed bag. So some have do have a strong cancer association, like AMPA receptor antibody, GABA B, and NMDA receptor antibody, PCA-TR, and then mGLOR1. But then there are lots of others where there is limited or no cancer association at all, such as LGI1 antibody. And very often these patients are more immune therapy responsive, and many have a good prognosis, particularly the LGI1 cases. So what about the approach to cancer testing? I think a lot of this depends on what you find. So if you find, say, ANA1 or anti-U, and you're thinking small cell carcinoma, either pulmonary or extrapulmonary, small PET-CT would be a very good way to scan for that. If you're thinking breast or gynecologic cancer, then mammography, breast exam, possibly an MRI of the chest, plus pelvic ultrasound, gynecologic exam, or an MRI of the pelvis. So largely depends on the antibody found. If the antibody has a kind of a high risk for cancer associations, I mentioned, we keep scanning those patients or reassessing them every 6 months. For patients where the tumor association is pretty weak, we will do a very thorough assessment, and if no cancer is found, we would recommend age-and-sex appropriate cancer screening from there. So from a treatment perspective, I'm not going to go into a lot of detail here, but this is just to give you a sense of kind of the sort of the repertoire of treatments that we can choose from. So a lot of the time we're doing initially treating patients with high-dose methylprednisolone or IVIG, or methylprednisolone with plasma exchange, to see if we can bring about a meaningful response, and then often trying to maintain that response then with the treatment like rituximab. For patients with classical paraneoplastic disorders that have a lot of disability, very often we're treating the cancer in the first instance and then trying to do some immune therapies in addition to that. And some of those patients might get cyclophosphamide 1 gram per month, or 1 gram per meter squared monthly for 6 months to try and treat that T-cell mediated disorder. But as mentioned, a lot of the time, the best we will see in those patients is stabilization. And then let's not forget symptomatic treatment that I mentioned in a few examples as we were going through. So in terms of future directions, I'm just going to briefly mention that we continue to evaluate autoantibodies in our lab for new targets. So here's an example of one that we saw in the lab that we didn't recognize what this antibody was. It was an unclassified antibody in our hands in a patient with ataxia. turned out that the patient had RGS8 antibody, and we were able to identify that by screening using a human protein array on a research basis. And then we were able to confirm that with a line blot. And so we're continuing to evaluate all of these novel antibodies. Other examples of that include SEZ6L2, which is pertinent to ataxia. So in summary, consider autoimmunity and subacute onset movement disorders, and then also in disorders with atypical features, MRI and CSF may provide additional clues, and then testing serum and CSF comprehensively based on the phenotype is what we recommend. And then antibody test results may provide guidance to a cancer diagnosis, and then consideration of trials of immune therapy, sometimes guided by the antibody result, and then also may give us some information about prognosis. And our lab continues to identify new markers all the time that we will add into our evaluations based on the phenotype associated with the antibody. And so here are some people I wish to thank from our faculty and lab staff and fellows, and also our NIH funding. Just also want to briefly mention a clinical trial for you in case you come across any patients with NMDA receptor antibody-associated encephalitis or LGI1 encephalitis. This is a randomized controlled trial of satralizumab versus placebo. In addition, the patients get a standard treatment up front with corticosteroids, IVIG, or plasma exchange, followed by satralizumab versus placebo. And if you have a patient that you think you want to consider enrolling for this or want to learn more information, there's a telephone number there for that. So thank you.
Yeah, thank you, Dr. McKeown. That was great. So now we're going to enter the question and answer period. If you have questions, submit them in the Q&A button at the bottom of your screen. I will say we already have 8, Dr. McKeown. So first off here, there's a question about refractory SPS and other GAD-associated disorders. Do you have any treatment recommendations for refractory cases of stiff person or GAD-associated disorders?
Yeah, so I think that the standard treatment for stiff person syndrome is to chemically treat with basically benzodiazepines, diazepam, or baclofen, by the oral route, and immune therapy, which consists of usually IVIG. That's the one drug that's approved. For patients who don't respond to that, then rituximab is a treatment that I've used in several patients and have had success. And there have been reports in the literature of success with that too, but it's not in every patient. Cyclophosphamide can be considered in these patients as well. A baclofen pump can be very helpful. So an intrathecal baclofen pump can be helpful for stiff person patients also. For the stiff person patient phenotype, that tends to be more treatable in general than the ataxias. So the cerebellar ataxia patients often, in my experience, they may have some slight improvements, but typically not big changes in motor milestones. And there are some patients who will continue to progress despite treatment. And so a lot of the time treatment is escalated in those patients to cyclophosphamide.
All right, thanks, Dr. McKeown. The next pre-submitted question here said, who should be the primary neurologist for patients with autoimmune movement disorders? They mentioned neuroimmunologist or movement disorder specialist. What would you say?
Yeah, I think sometimes or most of the time in my practice at least, it's a partnership. So as a neuroimmunologist, the patient will come to me and I'll evaluate and then make treatment recommendations. And unless if they live very close to the Mayo Clinic, those treatments are going to be implemented closer to home. And sometimes that can be a multidisciplinary team then, because not all neurologists, like the referring neurologist may or may not be comfortable with, they're probably comfortable with IVIG and steroids, but may not be with things like rituximab and cyclophosphamide. Of course, an MS specialist might be, and so they may be happy to do that. But sometimes patients will end up getting their treatment through, say, a rheumatologist or an oncologist. So we just try to make it work based on, kind of what the resources are available locally in terms of, primary care, neurology, neuroimmunology, and then allied specialties like rheumatology.
Team effort. The third one, do we have some integrative lab test panel for systemic inflammation assessment besides CPR or ILs? Dr. McKeown?
I'm wondering if that's CRP, which is kind of a marker of inflammation in the blood. We typically don't find testing in the serum for markers of inflammation is helpful for diagnosing these kinds of diseases. For other inflammatory diseases like vasculitis, they can be very helpful. In the CSF, then, yeah, there's research that's ongoing to look at the significance of interleukins, cytokines, chemokines, and spinal fluid in terms of maybe differentiating one disease from another disease. But that's quite preliminary at this point.
Okay. The next one says, what are the most common autoimmune movement disorders that laboratory professionals should be aware of?
I would say ataxia will be the most common. So cerebellar ataxia, then probably stiff person syndrome after that. The other ones are more uncommon, and sometimes they occur with encephalopathy. So that sometimes brings up the question of, okay, well, what profile should I order? I think if you have a patient who has, say, encephalopathy and chorea, it's fine to order either evaluation, but not both. I mean, there's no reason to order both an encephalopathy and a movement disorders evaluation.
Okay, great. Next, it says, is there a specific autoimmune movement disorders panel, or is the paraneoplastic one sufficient? They added a second question there about whether there's any yield in testing CSF.
Sure. So yes, the autoimmune movement disorders evaluation is available, and in fact, we have really segued to phenotype-based evaluations in general. So the first step with all of these is what's the neurological phenotype, then is it subacute onset, and then picking the evaluation on that basis, rather than a paraneoplastic evaluation, because paraneoplastic is really, it doesn't speak to the phenotype that the patient walks into the clinic with, it speaks to etiology or causation. So what we found over time is that a lot of the autoantibodies that are in that evaluation don't have strong cancer associations. And also there are more and more antibodies coming out with cancer associations that it just becomes unwieldy to have them all in one evaluation. So that's the reason that we're recommending at this point that people order the phenotype-specific evaluation. So encephalopathy, epilepsy, dementia, movement disorders, myelopathy, neuropathy, dysautonomia, and neuromuscular junction, which is myasthenia gravis and Lambert-Eaton syndrome. So that we should pick on the basis of how the patient presents neurologically. And we are really encouraging people to get away from the paraneoplastic evaluation, which in fact we are planning to obsolete pretty soon. So now regarding CSF versus serum, sorry, for the most part with the movement disorders, the serum covers a lot of things, but if you have a patient with, ataxia that has features on MRI that's suspicious for GFAP, or if you have a patient with kind of a suspected small cell lung cancer related ataxia, you would want to order the CSF too, because GFAP, neuronal intermediate filament antibodies, are not sensitively or specifically detected in serum. They're much better detected in CSF. Similarly, for NMDA receptor encephalitis, we do a better job of detecting that with the spinal fluid.
Perfect. Sorry about that, Dr. McKeown. A few questions have been submitted now in the chat. The first one asks, if serum GAD65 is barely above normal, can it be considered pathogenic?
No. Just to review that, the GAD antibody is present in healthy people. like 5 to 8% of people just walking around the place without any medical problems. 5 to 8% of them have GAD antibody at the kinds of values that that person asking the question is mentioning. So it has to be really interpreted with caution. However, there are autoimmune diseases that are fairly common in the general population that are associated with GAD. That includes type 1 diabetes. So you could have a patient who has, type 1 diabetes and maybe undiagnosed and has neuropathy, and that's the cause of their balance problem. Or you could have a patient that has pernicious anemia related to GAD autoimmunity, and they're B12 deficient, and that's the cause of their ataxia or their myelopathy. So there may be kind of indirect autoimmune relations. And the other thing is celiac disease. So celiac disease is commonly associated with a GAD antibody too. But again, it's the neurological problem is probably due to malabsorption of B12, folate, vitamin E, or copper from the small bowel, rather than it being direct neurological autoimmunity. So when we get into talking about GAD and direct neurological autoimmunity, we're really talking about orders of magnitude higher, so hundreds of nanomoles per liter typically, and always greater than 20 nanomoles per liter. Now that causes some confusion because there are some other labs that measure by ELISA, so they're talking in international units per ml. We have found that typically speaking, 10,000 to 20,000 international units per ml is roughly equivalent to 20 nanomoles per liter in our lab, which is kind of that cutoff for neurological dysfunction.
All right, great. There's a couple questions related to COVID-19, Dr. McKeown. I'll just lump them together. Have you seen any COVID-19 related CNS autoantibodies? And the next one similarly asked, has there been an increase in autoimmune mediated movement disorders related to COVID-19?
So I'll kind of answer the second one first. So we did survey the Mayo Clinic experience in relation to COVID-19 and encephalopathy, and we published it in Neurology. I think it came out last year, but the bottom line is that we did not find an increase in encephalitis among our COVID population. We did encounter a few occasional post-infectious seronegative autoimmune encephalitis cases. There are a lot of patients though who get sort of brain fog and pain and orthostatic symptoms after COVID, this long COVID syndrome, but that's different to encephalopathy. In terms of antibodies, as I mentioned, these tend to be seronegative, but there have been some occasional cases post-COVID of particular antibodies found. It's always a little challenging related to the time, does it have to occur within 2 weeks of COVID or a month or 2 months? So for instance, we've found a Septin-5 patient that developed it post-COVID. We had some cases that came through the lab at the height of COVID, like NMDA receptor, but antibody, but generally pretty uncommon.
Okay, great. I think we have time for one more question. It should be a simple one here. It says, is MA1, MA2 included in the Mayo movement disorder panels?
Ultimately, what we decided to do with MA1, MA2 is just to offer MA2. MA1 is kind of interesting in that typically the younger men who have seminoma don't have MA1, and typically the older patients with MA1 and MA2 have other cancer types. But we felt that it didn't give us enough differentiation to warrant bringing it up. So we just offer MA2, and then you can basically figure out what cancer to look for on the basis of the patient's age and sex. So we're just offering MA2, and then yes, eventually it will be built into those evaluations, or that evaluation. I think it's next year. Is that correct, Ben?
Correct. It's a standalone right now, but will be added in.
Thank you.
Okay. Thanks everyone for participating in today's webinar. If your question was not answered, you're going to be getting an evaluation that was put in the chat already, and feel free to include any questions that weren't answered in that evaluation, and we'll respond to them. And then as a reminder, the program was recorded and it will be archived on our website in a few weeks. So thanks so much for joining us today. Thank you, Dr. McKeown, and everyone have a great day.
Thank you, Ben. Thank you, everybody, for attending.